Hello, everyone. I'm Dr. Matthew Oliver from the University of Toronto. I'd like to welcome everyone for our inaugural webinar from the North American PD Catheter Registry, which is being co-hosted by the ISPD. The topic we've selected for our first webinar is something that I think is relevant to many people practicing in nephrology and in surgery, radiology, which is patient selection for PD catheter insertion. The topic, I'm a co-lead for the North American PD Catheter Registry, and joining me as well is Dr. Rob Quinn from the University of Calgary, who will help facilitate this session today. The webinar is going to be broken into a few different sections. First, we're going to have a brief slide presentation from Dr. Quinn, who's going to highlight some of our most recent findings from the registry, which will hopefully be sort of the launching point for discussion. And then we're going to have plenty of time to have a discussion with our expert operators. I know that in a lot of these webinars, it's the part where people talk and discuss different options that is the most informative to our audience. So before we get into the presentation by Dr. Quinn, I'd like to introduce our expert panel, starting with Dr. Christopher Morris, who is an interventional radiologist who's been placing PD catheters for over 30 years. Currently holds the position of Professor Emeritus at the Larner College of Medicine at the University of Vermont, as well as Adjunct Professor at the University of Utah. Dr. Morris is actively engaged in improving peritoneal dialysis by promoting access through interventional radiology and enriching peritoneal dialysis catheter designs. And I believe Dr. Morris actually has a patent for a new type of catheter, which should be interesting to hear about. Second is Dr. Todd Penner. He's a general surgeon and bariatric surgeon at the University of Toronto. He's been practicing for 22 years, and he's the director of PD surgery at University Health Network. He's been the primary operator for laparoscopic PD surgery at UHN since 2006. He's faculty for PDU for surgeons, protege and friend of Dr. John Crabtree, who many of us know here. And he's had years of experience with complex cases that's really allowed him to push the boundaries for people who might not otherwise be candidates for PD. And our third panelist, Dr. Arsh Jain, is an associate professor of medicine at the University of Western Ontario, practicing nephrologist, and he has deep clinical expertise in the area of peritoneal dialysis and catheter insertion. He conducts clinical and health services research to improve health outcomes for patients with kidney disease, and he is the lead physician for peritoneal dialysis access at his site. He also is a faculty for PD University for interventional nephrologists and interventional radiologists. So it is truly a blue ribbon panel, and I'm really looking forward to hearing our operators' insights as we get into the second part of the webinar. And now I'm going to hand over to Dr. Quinn, who's going to give a brief presentation to give us some food for thought prior to getting into the discussion.
Thanks, Dr. Oliver. We'll start just with our disclosure. So Dr. Oliver and I both have honoraria for speaking engagements with Baxter Healthcare or Vantive. We're the co-inventors of something called DMAR Systems. And Matt is currently the regional medical lead for the Ontario Renal Network. I'm the acting president of the North American chapter of the ISPD. So as Dr. Oliver alluded to, we're going to spend the bulk of our time in discussion with our experts. But to set that up, we're going to give you a little bit of background. First, about the history of the North American PD Catheter Registry. Where did this come from? How did it arise? And what's it all about? And then we're going to talk about some of the recent literature that's come out of that registry, specifically around patient selection for PD catheter insertion and some of the issues that we face in the clinic when we're trying to identify appropriate candidates for PD. And that'll be a jumping off point for the expert panel. During the panel, we're going to focus on various aspects. So the preoperative evaluation of patients, what goes on in the OR, which is a bit of a black box to many of us. Hoping our experts can shed some light on that. Post-op care of patients, and then how we measure our operator performance and future directions for research will kind of tie things up at the end. So back in 2014, so over a decade ago, Dr. Tom Golper set up a meeting of investigators and clinicians from around North America that had an interest in peritoneal dialysis. And at that time, we made a commitment that we as a group would work together to try to do some impactful studies in the PD space. and went through a bit of an informal priority setting exercise. And at the end of that meeting, the decision was made that we should focus on PD catheters, because while there was a lot of strong opinions about how best to place them and care for them, there wasn't a lot of science to back all that up. And anecdotally, many of the people that were there struggled with catheter complications in their own programs. So this was an area that we decided to focus on. After that meeting, there was an open call for people to lead the North American Research Consortium, and Dr. Oliver and I were selected to do that. And so we set about engaging operators and people that care for patients on peritoneal dialysis to build a data collection platform to capture data from the time of PD catheter insertion up until the end of the first year of therapy. One of the issues with many of the studies is that they were small, they were often single center, and it's expensive to capture big cohorts of patients. And so we went to our national funding agency called the CIHR, which is our kind of NIH equivalent, and got $1.4 million to take a deep dive into PD catheters. The focus of that project was around the influence of method of insertion on catheter outcomes, how operator characteristics or approaches influenced them, as well as center characteristics and how they impacted how patient did on peritoneal dialysis. And then at the end, the plan was to convene an experts consensus panel to tie all this together and make recommendations. We finished the collection of data this past year, and we were able to capture 2,500 catheter insertions at 23 centers, and we have just about 100 operators participating in the registry. One of the unique things about it is the quality of the information that we got. So every data point that was collected was reviewed by Dr. Oliver and myself, and we did audits of random sample of cases at each of the sites just to make sure that the data we were getting was robust and we could trust it. So the first series of papers that came out of the registry over the course of the last few years were around the evaluation of patients who are going for PD catheter insertion. And to kind of set the stage for our discussion, we'll go through a couple of those papers and some of those key findings. I mentioned before that anecdotally people had observed that catheter complications seem to be common in their centers. And nobody really had taken a robust look at this at scale to see if in fact that were true or whether we were just dealing with pockets of places that had low volume surgeons that maybe didn't have great outcomes. And sure enough, we found that catheter complications were common. So this is data from the registry. And the gray bars represent the outcomes at 3 months. The dark black bar is 6 months. And you can see that 1 in 4 patients by 6 months after insertion had a complication related to their catheter that led to either an invasive procedure, an emergency room visit, a hospital stay, or the termination of therapy. And when you looked at the distribution of the causes of those complications, flow restriction or catheter dysfunction was far and away the most common, followed by exit site leaks and pain, which affected 5 and 6% of the patients that we saw. The next thing we did was look at the consequences of those complications. And you can see that 6% of people either never started peritoneal dialysis or terminated therapy 6 months after insertion. Delays were common, as were emergency room visits and procedures. So about 1 in 10, 1 in 12 patients were visiting the emerge or getting hospitalized or undergoing some procedure related to their catheter. So this was a common problem. It seemed to be the case in most centers, and it was having significant consequences. So what are the clinical implications for the people that care for these patients? Well, I think, at a high level, setting reasonable expectations, both for ourselves, but for patients when we go for catheter insertion, and understanding that 1 in 4 are going to have some kind of catheter-related complication, but the majority of those patients will get through and continue on therapy. About 1 in 10 are going to have a catheter-related procedure or will have an emergency room visit or hospitalization because of these complications. And when we're watching for common things in the first 6 months after catheter insertion, flow restriction, exit site leaks, and pain are the 3 most common things we're going to run into in clinical practice. The second issue that came out was whether or not a history of prior abdominal surgery should influence our decision-making about who's appropriate for PD catheter insertion. And the reason this comes up is that in a lot of centers, this is considered a contraindication to attempting a PD catheter, but there's certainly a wide variation in practice. In the registry, there are a number of different types of surgeries that people have undergone, and about 30% of the population of patients that went for a catheter insertion had some prior abdominal surgery. In women, those were most commonly GU procedures, so prior ovarian surgery, hysterectomy, C-sections. Appendectomies and cholecystectomies and hernia repairs, as you would expect, were relatively common in this population. And then a subset had had a prior catheter inserted, had a failing transplant or failed transplant, or had undergone nephrectomy in the past. So quite a range of different procedures in the belly. And the reason we worry about these is that prior abdominal surgery we know is a risk factor for having adhesions in the belly. And if you have adhesions, we worry that that's going to cause problems with catheter function and lead to catheter complications. The problem was that this had never really been looked at in a large cohort of patients, and the small studies that we had really didn't draw a strong link between adhesions and catheter-related complications. So we decided to look at this in our cohort. When you compare people that had a history of surgery to those that didn't, they had a slightly higher risk of catheter-related complications that led to either termination or interruption of therapy. So 22% versus 18%. But when we adjusted for patient characteristics, the risk was really no different between those groups, at least among patients that had been referred for PD catheter insertion. So this was a bit of a surprise. And the second thing that we noticed was that most of the difficulties were associated with interruptions in therapy rather than termination of therapy. So it wasn't that they were stopping PD altogether, it was that they had these interruptions or breaks in therapy and subsequently were put back on. If you look at other outcomes related to these catheter-related complications, there was no difference again in the frequency of ER visits or hospital stays or in invasive procedures to address these catheter-related complications. So we really did not see any signal that prior abdominal surgery led to worse catheter outcomes. So the next thing we did was ask the question, well, in the clinic, we can ask about a history of prior surgery, and that may or may not lead to a higher risk of complications. What happens when you go into the OR? You're putting this in laparoscopically, you can visualize the belly and you see adhesions. Does that actually portend a worse prognosis? And again, we saw a higher risk in people that had adhesions present at the time of their PD catheter insertion. So 17% risk of flow restriction or pain that led to procedures or termination of therapy, compared to about 10% in those that didn't have adhesions present. So there was a higher risk if you had adhesions present. This is a marker of somebody who's at higher risk for complications. But again, the absolute risks were relatively low, and we're still talking about the minority of patients. The other thing we noted, which is well known to surgeons, but maybe not so much to nurses and nephrologists and people that care on the medical side, is that there are a lot of people that will have prior surgeries that have no adhesions, and similarly, people that have had no history of prior surgery, and you get into their belly and they do have adhesions. So it's not as simple as saying prior surgery equals adhesions or not. It's often a little bit more nuanced. So we were able to show prior abdominal surgery led to an increased risk of adhesions. And if you had adhesions, you're at higher risk of catheter complications. But simply asking the question, if you have prior surgery, do you have a higher risk of complications? The answer was no. So the bottom line was that for us in the clinic evaluating patients, simply having that history is not enough to sway our decision making one way or the other, because the increase in risk is small if it's present, and certainly not big enough that it should influence our decision making in most cases. Now, there's going to be exceptions to that, but overall, that's what we saw. So in terms of clinical implications of these findings, it really does beg the question, should a history of prior abdominal procedures influence decision-making? There's obviously a range of prior abdominal procedures or issues with the abdomen, from penetrating trauma and bowel perforation to an elective procedure that only influences the upper abdomen. And obviously there's some nuance to this that hopefully we'll get into with the expert panel. But the signal overall was that prior abdominal procedures didn't seem to influence outcomes too much. So with that, we'll turn to our expert panel. And as I said, we're going to go through a series of topics from the preoperative evaluation all the way through to the procedure itself and the post-op care of patients. While we do that, I'd ask that if you have any questions, to make sure you enter them into the Q&A section. We'll try to monitor that and get to as many of them as we can during the discussion. And if we're unable to get to all of them, we will follow up after the webinar and try to address them. And with that, I will turn it back to Dr. Oliver.
Thanks, Rob. That was great. So I have a series of questions which I'm going to ask, and I'll direct them to individual experts. But after that expert answers, the other panelists are free to chime in with their responses as well. And as mentioned, we are going to monitor the chat and try to incorporate as many audience questions as possible so we can make this sort of participatory. So my first question is for Arsh. And it's about referral for PD catheter insertion. So, the doctors and the nurses who don't do the procedure are referring the patients. And what information do you want to see with that referral? Are there things that you kind of wish people did better when they referred? Can you kind of take us through the kind of wish list of what you would like to have or what we should be thinking of when we refer a patient for PD catheter insertion?
Yes, super good question, and thanks for having me on the panel. It's a bit of a challenge if the patients aren't coming with information with regards to like their previous surgeries. Do they have any hernias? Their kind of keenness or how interested they are in PD and how close they are to needing dialysis. Without those bits of information, it gets difficult to kind of triage patients and understand where they're going to go. I really think as a interventionalist, it's crucial to see the patients and assess them prior to going for the intervention. But the information that we get from the kind of referring docs often is somewhat lackluster. So that's why, having that interaction with the interventionalist I think is key.
And do you need a detailed list of operations? I mean, we tried to get all the operations in the registry, and it can be challenging because some of the operations are quite remote. Would it be helpful if we did our sort of due diligence and try to really list that operative history before the patient is referred?
Yeah, like things like, so for example, if someone had a hernia repair with or without mesh, it takes quite a bit of digging for the interventionalist or whoever to go back and find out what happened. So those bits of information, ideally, we'd like to have those before we're seeing the patient, because it really impacts my decision making around which way I should go. Should this be a percutaneous insertion? Should this be a surgical insertion? That kind of thing. So ideally, like anything abdominal related, I don't think I need every single detail about non-abdominal surgeries, but all abdominal related surgeries I think are important.
Todd or Chris, did you have anything to add to that?
Sure, I'll pipe in here. At University of Vermont, as well as I believe at University of Utah, we receive referrals from nephrology. So a lot of these patients have already been really well evaluated and vetted. And in addition, they're also seen by our home dialysis nurses, who are also very good at a lot of these screening questions. So we were seeing all these patients in our interventional radiology clinic previously, but our clinic just got so congested that it turned out that it was delaying some of these procedures. So more recently, we have not been seeing them other than the day of the procedure, ahead of time. And but I think a lot of that evaluation work is being done by our home dialysis nurses and our nephrologists ahead of time. So it's just a little bit of a take, because we're not nephrologists, we're interventional radiologists, whereas Dr. Jane is a nephrologist.
Todd?
Yeah, thanks. Thank you, Matt. Yeah, I agree with all the previous comments as well. And as the surgeon of the group, I see all of our patients in combination with our PD nurse coordinator, who's often done some pre-screening of the patients and adding extra history and preparing for the clinic. The only thing I do in advance, I see them all in clinic before the day of surgery, of course, and we do a physical examination on everybody. In addition to that, what we're always amazed at is that in my referrals at University Health Network, about 75% of our patients have had a previous CT scan. I almost do routine review of CT scans, also looking for incidental hernias and incidental findings as well that could influence the surgery. And I say that because as the surgeon in our group at UHN, that UHN has interventional nephrology and has interventional radiology. So my patients are kind of selected in a way to be the complex slice of that pie. So I do a little bit of extra in terms of evaluating for PD insertion.
You raise a good point about hernias. I was surprised that about 20% of people registered and put into the registry either have had a hernia repaired or have an active hernia. I'm sure, Todd, you are much better at finding hernias than I am, but do you find, like, on clinical exam that we're pretty good at detecting the hernias? Is a surgeon much better than a nephrologist? Or in some cases, they're just incidental and they can only be seen on imaging?
Yeah. Well, surgeons have more experience perhaps with hernias, but I found that the nephrologists who have identified hernias are correct most of the time. The hernias that are difficult to detect are the patent processus vaginalis. They're the ones that isn't a clinical hernia, but is the embryologic remnant of testicular descent that occurs in probably almost 20% of men. That is the cause for all of your scrotal swelling after PD that's incidentally found. That is easily identified on laparoscopy, but not physical examination or even routine CT imaging.
That's a great point. Yeah, I mean, so that somebody could have a scrotal leak and it just was not possible to be detected prior to the operation.
No.
The next thing I want to switch to is how do we decide between a percutaneous and a laparoscopic route? I'm going to send this to Arsh because, I mean, Arsh, you're probably maybe making that call, or often nephrologists are making that call, or nurses in the clinic before it even goes to the operator. So Arsh, can you take us through your decision making in terms of where you go percutaneous and where you go laparoscopic, or interventional radiology too?
Yeah, super good question. So in my center, all the patients come to me, and then I decide which way they go. So that I do have a lot of experience with this. Our tendency is, if there's anything there with regards to, a hernia or some kind of complicated abdomen, like obviously they have an ostomy or iliac conduit, or if they had significant previous surgery. So what I mean by that is some type of bowel resection with primary anastomosis or otherwise previous liver transplant, those kind of things. Those are the patients I'm sending over to surgery. We have a thought process around hernias where if I do identify a hernia, I will preferentially send that to the surgeon because, again, we have good access with the surgeon, and we'll kind of get a two-stop, 2-for-1 in that type of a scenario, fix the hernia and get the PD catheter in. And sometimes these are like subclinical hernias, but we just know that this might be a problem going forward on PD, and therefore, get it fixed all at once. I don't think it's necessary in many of the cases that if you didn't have access to a surgeon and needed to do the hernia repair later on, I think that would also be okay.
And Chris, how are you finding when you get some people referred and you think, no, I don't think we're comfortable doing this radiologically? Or are you pretty aggressive on who you'll do the procedure on, given you have all the imaging available to you at the time?
Sure. So at Vermont, about 95% of all the PD catheters are placed by IR, which means basically image-guided percutaneous placement. When we see cases of known adhesions or extensive, a history of extensive prior abdominal or pelvic surgery, we then consider asking one of our surgeons to place the PD catheter laparoscopically. However, we also talk to them about, potential lysis of adhesions at the time, omentectomy and omentopexy, all those types of ancillary procedures. But they seem to be rarely performed for some reason. So, our problem is at Vermont, we don't have a surgeon dedicated to PD catheter placement. So we're asking our general surgeons to place them, and they're very willing to, but we don't have, a Dr. Penner available to us, unfortunately. In Utah, interventional radiology is placing more and more of the catheters. I don't know as well about the extent of surgical involvement at this point, though.
Yeah, and a common misconception that comes up is, can adhesions be seen on CT? And my understanding is generally not, right, Chris? It's really not something that you can CT a belly and see a bunch of adhesions versus the direct visualization laparoscopically. Is that correct?
Yes, that is correct, unless the adhesions are so severe that they're causing bowel obstructions and those types of things. But generally, we do not see adhesions on CT scanning.
Great. Rob, are you monitoring the questions? Did you have anything you want for this section?
Yeah, there was a couple of things that came up. So first, a couple of questions just around what's captured in the registry. So buried catheters are captured. There was a question about whether we captured them or not. And then one for the operators, just in terms of information and screening patients before referral, how do you view a history of diverticulitis? And there was a question about whether or not you saw that as an absolute contraindication to peritoneal dialysis. So maybe I'll let you guys answer that one.
Well, I'm happy to pipe in on being the surgeon. I can speak about diverticulitis. I think, like it was in my introduction, I'm kind of my role, I feel, at the UHN is to be the one that pushes the envelope a little bit. So I guess my attitude is I'm always trying to say yes. I'm always trying to not exclude people, and rather to include everyone when possible. So I'm looking for, rather than looking for a simple reason to exclude everyone, I'd rather look for the major reasons to exclude only less patients, and that would be patients with recurring and active infection that is requiring recurring bouts of antibiotics. I probably would exclude them initially until that condition was more definitively managed, let's say with surgery. But on the other hand, if someone had a mild attack of diverticulitis and it was remote and it was a long time ago, most of those patients don't have ongoing issues with ongoing sepsis. And if I thought they were otherwise a reasonable candidate for PD, I wouldn't let that be a contraindication. And that goes with other, not just diverticulitis, but perhaps other inflammatory conditions of the abdomen as well. Someone who had gallstones, I wouldn't let that be a contraindication necessarily, or someone who had some other inflammatory bowel disease or something else like that, that was a chronic inflammatory condition. So I'm looking for a reason kind of to say yes, but that's also the unique position that I'm in. So I have experience, and and probably because of that say yes approach, I might even have a few more failures because of it as well. So when my results come out on the database, I might not look very good, in fact, because I am the one kind of pushing the envelope in some ways, and there is a bias towards the selection process of the things that I do.
Yeah, that's a great point. And that this is kind of one of the eternal questions, is how percutaneous compares to laparoscopic. And laparoscopic surgeons are getting more complicated cases, and so that needs to be adjusted very, very carefully. And then you're even making the point, Todd, that it's not even within laparoscopic surgery. You could be, as you say, pushing the envelope and taking complex cases. So that's a great point. I want to turn our attention now to sort of how your technique changes based on patient characteristics. And before we get into all the different tools that the laparoscopic surgeon has, I'd like to speak to Chris and Arsh about how do you modify your insertion technique based on the patient characteristics in the evaluation process?
I don't. Similar to what Todd's talking about, like if you have a previous appendectomy or previous cholecystectomy, simple procedures like that, C-section, hysterectomy, it doesn't really change my approach to the way I insert the catheter. The physically the way the catheter is inserted is fairly consistent every time.
And extended catheters, is that in your repertoire, or are those surgical?
Yeah, so extended catheters, like particularly like pre-sternal catheters, the tunneling instrument, like it's this vascular tunneler, it's like huge, and requires quite a bit. It would be quite painful if you didn't have a general anesthetic, I think. So it's not in my repertoire. Even upper abdominal catheters, for me, we don't tend to do that. We can definitely make the exit site fairly remote, but not true upper abdominal catheters.
And just for the audience, can you just explain a little bit of the extended catheter? People may not know that.
Right. So catheters, like typically, like they're in the abdomen, and you don't need an extension piece. You don't need to make the catheter longer in order to find the exit site. But for some people, they want the exit site to be hidden, or if they like to go into a hot tub, they want the catheter higher up in their chest or something like that. So that's like a pre-sternal catheter. Or same you can do with the upper abdominal exit site. And inside the skin, you have to actually add a piece to extend the catheter a little bit longer in order to reach those exit sites.
Great, thanks, Darcy. Chris, do you modify your insertion technique based on patient characteristics at all, or?
I'm pretty much in the same boat as Dr. Jane. Don't really modify it, but getting back to the diverticulosis question, diverticulitis. There's a spectrum of disease. I mean, some patients has they may have one or two diverticula in their colon. They're called they're labeled as having diverticulosis. But the patients that have the really severe cases of diverticulosis, I mean, the catheter can sit on those diverticula and cause some inflammatory change and pain mainly. And I've seen a number of those patients not tolerate PD. So I'm a little careful with really severe diverticulosis. And certainly, if it's an active inflammation, if an active infection with diverticulitis, I think that's somewhat of a contraindication, at least a relative contraindication to PD at that point. Regarding the pre-sternal or the catheters coming out the chest, it's really not, the subcutaneous space really is not painful to tunnel. It's just the skin has most of the nerves. So we do most of ours under moderate sedation. Occasionally we'll use general anesthesia, but it's generally, I haven't found it to be any more painful for the patient than a standard abdominal exit site. So it's not that I just think that it's in those mainly obese patients that like want to sit in a bathtub. I think it's a good option for them to have that exit site up high in the pre-sternal area, and it's not much of a anesthesia issue to get those in.
Interesting.
I wonder
Todd,
if we should move on, Matt, maybe to the next section. We're getting a ton of questions about the operative procedure itself.
Yes.
Of course, all the non-surgeons want to know what happens in the OR. So maybe we should move on just in the interest of time to make sure that we get through that part of the discussion as well.
Okay, so talking to patients about catheter insertion, is that what you're referring to, Rob?
Yeah, sure.
Yeah. So now we want to get into informed consent and just what you tell patients. Like I sometimes tell patients, the first 3 months of PD can be rocky and you need to expect it, and it'll smooth out once we get all the complications figured out. What are you telling people, Todd, about when you put in, what is sort of your standard spiel with people? And do you think they understand there is some complications potentially down the road?
Yeah, I mean, as a surgeon, I talk about the normal things we always talk about in surgery. There can be risks of anesthesia. The majority of my patients have general anesthesia, but I actually I'm one of the few that probably does 10% of my cases under laparoscopic conscious sedation, which is something I did learn from Dr. Crabtree, and that's a pretty rare thing to do. But I talk about the risk of anesthesia, the usual things, and mainly the catheter specific things are that we do have a small risk that catheters that have a mechanical non-function. And I tell people that sometimes they require a second procedure, and we talk about the possibility of developing hernia that would need repairing as well. Nothing too specific. Our complication rates are low, and I don't get too elaborate on complications.
Harsh, similar, or do you get into sort of the longer term, sort of 90-day type complications that people can get?
Yeah, I mean, aside from the immediate complications, procedure-related complications, I will often mention to the patients just that it will take a while for things to settle out. I don't really put a time frame on it, and maybe I should, but I do try and mention that to them, because the degree of frustration people have when initiating PD and it's not going well, and sometimes the pain that they can have, I think it's important that they know about that, and hopefully their nephrologist and the PD team is talking to them about those things.
Chris, anything to add there?
Yeah, I tell them that there are short-term as well as long-term risks. I tell them that there's a rare but real risk of infection, bleeding, pain, bowel injury during or soon after the placement procedure. But I also tell them that if I thought any of those complications were likely, I wouldn't be doing the procedure, and that the benefits far outweigh the risk. And then as far as, the long-term and success rates, I tell them that when PD works well, patients usually like it and prefer it over hemodialysis. However, unfortunately, PD does not always work well, requiring catheter revision attempts and sometimes catheter removal and transition to hemodialysis. I don't want their expectations to get too high, but we're going to do our best to make it work out for them.
And Matt, maybe I'll just follow up with Todd about a question we got in the chat here. There was a question about how you deal with the incidental inguinal hernia that you uncover at the time of laparoscopy. Is this something, and you kind of touched on this, but do you consent people for that ahead of time or warn them about that? How do you deal with that situation?
I went through, I think that's a good question, because I did go through a phase where I was routinely consenting all patients for the possibility of incidental inguinal hernia. And I actually think in a perfect world, if I could do whatever I want, whenever I want, that would be an ideal type of practice if one could live in this perfect world. I live in a real world, and I found one day, I think I did in my 5 PD cases in a typical PD day, I think I had 4 or 5 extra hernias, and we really ran late, and my operating room wanted to cancel one of my cases. And out of purely logistical but not clinical reasons, in my particular case, I went away from that practice only so somebody wouldn't lose the option to have the opportunity to have dialysis that day, because my operating room can tend to be a little restrictive at times to running late when adding incidental procedures. So when we do run into an incidental patent processus vaginalis, I document it, I communicate it to the unit, and then we try to get them in as quickly as possible, because invariably I can see with very high probability that they're going to have a lot of scrotal edema afterwards. So I do the repair later under local anesthesia.
That's great. And maybe we'll move on then, Matt, to the next kind of section around what happens in the OR, because I think there's going to be a lot of questions about this part.
Yeah. Okay. So yeah, I was going to ask this before, but Todd, could you tell us how you modify your technique based on patient characteristics? You have a few things like omentopexy, adhesiolysis. How do you employ those different techniques, and when?
Yeah, thanks, Matt. That's a good question. So yeah, there's only a few things in my armamentarium. I think the other panelists talked about tunnel catheters. So initially I also do tunnel catheters to the pre-sternal area and upper abdominal, depending on, usually it means that there's not a good exit site with a standard abdominal catheter. Most common reason would be obesity. I do surgery on people with stomas and ileal conduit and other issues. Then those are the ones that we tunnel to the pre-sternal area. For techniques like rectus sheath tunneling, I mean, I'm sorry I don't have a diagram for anyone in the audience who doesn't know what this phrase means, but that is essentially tunneling the catheter not directly through the layers of the abdominal wall, but kind of at an angle, almost angular penetration through the abdominal muscle, in order to use that as a way to stabilize the catheter so it can't move and it can't spin and it can't pivot. So it's actually fixating the catheter toward the pelvis, so it's really virtually impossible for the catheter to move. And that's in lieu of other procedures that have been described for PD catheter insertion, where sutures are used, or things to hold catheters in the pelvis. So I do that routinely because that's my fixating technique as per Crabtree. And we don't suture the catheter down in the pelvis, but rather we use rectus sheath tunneling. Omentopexy. The omentum is the most notorious organ for wrapping around catheters, and I have 100 videos on omentum wraparound catheters, and I mean, I do all the salvage procedures as well at our hospital, so I have a lot of experience with other techniques where there's omental wrapping, and the omentum is the enemy of the PD catheter. And when I see a long omentum that reaches the deep pelvis, I will do this prophylactic omentopexy, a single suture that holds the omentum in the upper abdomen away from the pelvis. And that has been a very reliable way to reduce the risk of omental wrapping. Let's see, what else do we have there? Tunneling, omentopexy, omentectomy. That's another good question. So the different omentopexy, of course, just means the suture to hold it out of the way, but omentectomy has also been well described in the literature as like resecting of the omentum. Now that turns into a big procedure. I try to not do big procedures in PD because big procedures tend to be bloody and painful, and you need to take out an omentum, you have to have a big incision to take it out. So that would never be my preference, to actually remove the omentum when I could just sort of tack it out of the way and be just equally effective.
And the adhesiolysis, we were discussing not all adhesions are created equal yesterday.
Yeah, that's the best question of all. Yeah, so adhesions. So here's how I, as a surgeon, think about adhesions, because it's very difficult to capture in the database, because of course not all adhesions are bad, and just the presence or absence of adhesions is probably not going to be a good predictor for the outcomes, for the mechanical outcomes of peritoneal dialysis. So I think of adhesions, like bad adhesions, as being in two categories. So bad adhesions is one's category A is the adhesions that prevent the catheter from just reaching the deep pelvis. So there's and that's the kind that, as a bedside operator, that you might run into. You're trying to put the catheter in the right spot and you're hitting some kind of a barrier. It's not going down there. So they're just blocking the pelvis. So those are kind of quote unquote bad adhesions. And the second category of quote unquote bad adhesions are the ones that cause compartmentalization of the abdominal cavity. And what I mean by that is, instead of having free flow of PD fluid around the organs of the abdomen that's going to allow for easy drainage, the compartmentalization means that it's just going to be fluid that fills up a sort of a compartment in the abdomen, and it's not going to easily cross into other barriers where the catheter may be. And there might be different compartments within the abdomen related to adhesions that are preventing the easy, fast drainage that is required to have a good quality of life on PD. So when I see blocking of the catheter into the pelvis or compartmentalization, those are the only ones that I'll perform an adhesiolysis on. And of course, just to be extra confusing, there's many adhesions that are actually beneficial for PD. So not like even the oversimplified idea that adhesions are bad. Of course, many patients have upper abdominal surgeries. The old-fashioned open cholecystectomy is a common one, where the omentum is often tacked nicely to the upper abdomen and actually forms this perfect free omentopexy that I didn't have to do, because it keeps the omentum out of the pelvis and actually improves the outcomes of peritoneal dialysis in those select cases. So the bad adhesions are preventing the catheter from reaching the pelvis properly. So that means mainly pelvic adhesions. And the second one is compartmentalization. All the other adhesions are kind of incidental and don't affect the outcome.
That's great review, Todd. I just would point out that since doing the adhesion paper, I am more cognizant of really reading that OR report carefully. And if your patient at baseline has adhesions that had to be dealt with in the OR, I make sure the patient and the families know about that, because it could increase the risk of complications later. And it was there at baseline. It wasn't necessarily related to something afterwards.
Can I, Matt, just jump in there and ask a quick question?
Yeah.
I mean, maybe stir the pot a little bit. One of the things we're seeing in the UK PD catheter registry, where percutaneous placement's much more common, published their finding comparing percutaneous versus open or versus surgical placement, and really didn't show a huge benefit of surgical placement. And in fact, percutaneous placement, looked quite good, if not slightly better. In the US, we saw the opposite. So the most recent data out of the US would suggest surgical placement is better. When you kind of see those results, how do we interpret that? And how much do these special techniques that you can do with laparoscopic PD catheter placement influence outcomes, in your opinion? And if they do, why is it that in some places percutaneous placement looks so much better? Is this just a selection issue, the patients that are getting one technique versus the other? How would you kind of reconcile that?
Is that a question for me?
Sure, you can start.
Well, there's a few procedures that laparoscopy offers that other techniques do not have. And one, there's direct vision of the peritoneal cavity to evaluate adhesions in the way that I just mentioned, are they good or bad adhesions, and it can offer immediate lysis of adhesions when necessary. It can identify incidental hernias like patent processus vaginalis that may not be available on routine imaging or other bedside techniques. And it has the option of, under direct vision, the angulation of the catheter through the abdominal wall. So I think unequivocally it has that gold standard of having every aspect of what PD surgery does require. Now, I realize that the results don't always reflect that, and could there be, there's a lot of surgeons out there who don't have the experience interest or investment into dialysis catheters that I'm suggesting to you today. And there's many different techniques out there that are not excellent. And in those cases, I'm sure that that a dedicated bedside practitioner could get equal or better results in many of those situations. However, I will defend I'm here to defend the laparoscopic insertion technique, and at the very least, when it's available, it does have all the aspects of the best potential for excellent results, and it's even used as a salvage for other techniques in cases of omentum or hernia when there's and adhesions when there's other issues with other techniques.
Thanks, Todd. I want to make sure I shift over to Chris and ask a couple things. In terms of testing the flow immediately after you place a catheter, do you have a sense that this catheter is going to work well? And if you could just touch base, Chris, because you're the interventional radiologist, on manipulations and the ability to move catheters, because I know sometimes rectus sheath tunneling can sometimes affect the ability to move the catheter because it isn't sort of pointed down. Can you give us a sense of that?
Sure. Well, first of all, when we do place them, as Dr. Penner was explaining, we do use this, what I call a zigzag approach. We go in at about a 30-degree angle from the skin and then try to place our needle horizontally through the rectus sheath, and then we flip it up and try to go about 30 degrees or 60 degrees down into the peritoneal space at that point. And that's I think what he was describing earlier. That doesn't really change the ability to manipulate the catheter at that point. We don't consider the procedure complete until we make sure that the active end of the catheter, the coil, is down in the cul-de-sac of the pelvis. Now, sometimes after we do our test that you were mentioning earlier, and what we do is we just use gravity to test the flow rate in, and then we put the drainage bag basically on the floor and test the drainage out by gravity as well. And we're trying to get to those, at least 100 cc a minute flow rates, and we're generally a lot higher than that. But if it's less than that, then we know there's an issue. We relook at the location of the catheter, and often those catheters are already floated out of the deep pelvis. And then so we're trying to, push it back in. We use different techniques to do that. Dr. Jane knows all about these. We're using catheters and guide wires, or a metal stylet that we put a curve on it, and we can advance that through the catheter and push it back down. And that's actually how we revise migrated or dislocated catheters on a chronic basis as well. And that's how. And even when the exit site is well healed, we can still get those metal stylets through the catheter that way. There's a elasticity to the catheters that tolerate that pretty well. I don't know if that's if that's answering your question, but those are all the techniques we use. The bottom line is, through image documentation, we want to make sure that catheter's in the deep part of the pelvis at the completion of the procedure.
Yeah, that's great. Rob, questions? I have another thing I want to follow up in terms of immediate post-op care and flushing. I've heard some people say, like, if there's an extensive procedure, maybe there's a bleeding, there's adhesiolysis, or that flushing should be more rapid, flushing should be more frequent. Do you practice that, or should people be flushing catheters more aggressively if they think the procedure is more extensive? Or just flush till the effluent is clear?
Yeah, I'll take that one, because I do a routine debrief and follow up in the form of an email with the PD unit after each one of my PD operating room days. And that'd be one of the things I would say in the debrief after every single patient back to the unit, is if I was in a situation where I did an extensive lysis of adhesions, if it was a bloodier operation, then I would recommend early flushing. And our unit would start probably the next day of flushing the catheter and they would probably keep doing that daily until it was clear.
One of the questions that's come up is the actual flushing procedure and what we're using for flushing. There is some literature around the use of icodextrin, for example, to prevent adhesions in the general surgical literature. Is that something that you guys have come across? How do you approach that? Do you think that the solution we use to flush these catheters makes a difference? Is that an area that maybe we should be investigating further?
Yeah, I mean, I think that literature is pretty interesting. In the gynae space, there's thoughts that there's some benefits to icodextrin reducing adhesions. I think from a percutaneous inserter perspective, like I don't feel like, and I don't know, but I don't feel like I'm creating a real big inflammatory reaction inside the abdomen with, putting a needle in and then a wire and then the catheter. So I'm, hoping that there's not a huge burden of adhesions that happen as a result of that. So generally speaking, for flushing, we're using just the regular dialysate solution. So like we use Baxter Solutions Dianeal. Those have a low pH and can be a little bit stingy. So sometimes people have to be aware of that fact, but once they get used to it, it's not too bad. The other option is using a low GDP pH neutral solution.
Okay, I want to switch in the final bit here to outcome performance, and this is something we feel very passionate about. But I guess I'm going to ask sort of a first question for the audience from the audience's perspective. If you were concerned about the performance or complications of PD catheters in your program, like what would be some of the things you would look for? Is there a number you kind of would be worried about that you think you might have an issue? And how would you approach sort of tracking your outcomes, and do you do that locally with your unit? Maybe start with Arsh, if you don't mind.
Yeah, super good question. I think that there's one thing about developing confidence to do the procedure. I think you need a lot of catheters to do that. And, my feeling is like 50 is what you need. And then there's the other option of staying competent, which I think as long as you're doing them not infrequently, 20-ish a year, probably you're going to maintain competence. And a lot of the tools in interventional, approach with ultrasound and fluoroscopy, like it really helps you orientate yourself. So, as long as you're used to using your hands, it's hopefully not something you're getting away from. So I think that's kind of how I look at kind of competence and maintaining competence.
What about the complications themselves, though? Like Todd and Chris, do you have a good sense of, are your catheters working, or you only know if they come back to you, or do you have performance or outcome tracking in your program?
Well, of course, we rely on our home dialysis program to track all the patients, which they do pretty carefully. They certainly let us know right away if there's an issue and get referred right back to us for a revision or whatever needs to be done at that point.
Todd, is that kind of similar at UHN?
Yeah, we being an academic center, we of course have our own database, and all the operators have their own results. But also, I get another round of feedback because I see every catheter that doesn't work from every operator because I'm the sole avenue of salvage. So we get to review techniques and see. We have had operators who have had problems in the past and have improved the technique to get better results. So we've had quality initiatives that have improved outcomes.
Because one of the things we definitely have a lot of data and a lot of benchmarking, and one of the things we're thinking of doing is trying to develop a bit of an outcome report, for something that's relatively simple, of course not punitive in any way, but would that be useful to programs to kind of have something they can benchmark against others for some simple outcomes that they know is fairly accurate? That would be helpful.
I think absolutely yes. Like, primary non-function and leak rate, some of these things are really important and also helpful for the patients to know what their risks are when you're talking to them, preoperatively. So it would be great if as a community we could get together, standardize some of the way we define these things, and then track them going forward and put the data together. I think that'd be a great help to the PD community at large.
Maybe
You know,
follow up on that, because I think, you know, your answers to this last series of questions actually raise an important point, which is in many places in the world, the numbers of procedures that people get each year can be quite small. I was really struck by the US data when it was published that, you know, the average person, the median number of catheters in some cases was 1, 2, 3 catheters per year. So it's much smaller than maybe the higher volume centers that are typical in Canada or elsewhere. Do you think that we need to be better at kind of looking at operator outcomes? Do you think that volume plays a big role, and that's something we need to examine, because it has implications for the way we structure care? You know, if we're going to say that people should get 20 catheters a year, then that means that we're going to have to refer them to higher volume centers. What are your thoughts on that? Maybe Arsh, I'll start with you.
Yeah, I mean, I I think that if you're only doing 1 or 2 catheters a year, it will take you 10 years to have even any sense of your data. Like it's like not really a, you know, maybe a great go-to strategy in my mind. I think going to centers of excellence or centers of practice, as we call them in Ontario, where there's some incentive for them to be doing your PD catheters, it works well, and it, you know, helps facilitate the interaction between centers who maybe see a little bit less PD and centers who see more, so that there can be some communication around how to deal with some of the complications.
And Chris, can you comment on that from an American perspective? Because the way care is structured down there is so much different. It's often a little more fragmented, and
Yeah.
you know, you struggle already to kind of grow the home programs, and then we're going to introduce this situation where we need to refer to higher volume operators to get PD catheters placed. Is that going to be a barrier? Is that something, you know, what's your thoughts on that?
Well, there's certainly, you know, pros and cons to that. I mean, there's no question that increased volumes makes better proceduralists. Data has been, you know, that's been proven time and time again. But there's also access to care issues, and there's so many smaller, medium, and small size hospitals throughout the US. And in addition, I just have to say it out front that interventional radiology is not in the United States has not really developed an interest in PD catheter insertion. That's kind of what I've been trying to do over the last 15 years to promote that among the interventional radiology community. But I think it's probably Dr. Jane could speak to this more, and Dr. Penner as well about in Canada. I think interventional nephrologists and interventional radiologists are more apt to be willing to place them than in the United States. So it's sort of a mixed bag, I guess is what I'm saying. But just to isolate the placement of PD catheters at big centers is going to really limit the availability of how many patients then will be able to get percutaneous placement of PD catheters in the U.S.
Thanks, Chris. So we're in the final few minutes here. Have we caught up on all the questions, or is there any burning questions there, Rob?
I guess a couple of quick ones just from a technical standpoint. There was a question about exit site stitches. I think I know the answer to that one, but they're generally kind of discouraged, but maybe an important point to make. Todd, did you want to comment on that?
Yeah, thanks. That's an easy one, because that's an absolute forbidden exit site sutures. Anytime in surgery we are using sutures in the skin, we're going to develop little pustules and suture abscesses that often contain Staph aureus and other things that we don't want around the exit site of a catheter. So there are so many other ways to fix the catheter in the early post-op period. Because I guess, what's the reason that a surgeon would put a catheter in? And the idea would be that you don't want to move. You want to stay and heal into its location. But there's so much actually better ways to do that. And we just do that with a very large dressing that fixes the entire catheter and almost covers the whole abdomen without having any movement on the catheter itself, and it avoids those stitch abscesses. Stitch abscesses is a kiss of death, because if you get one of those, 3 months later you're going to get some catheter colonization, and your catheter survival is gonna go down.
That's great. Thanks. The only other thing that came up from a technical perspective was choice of catheter. So the intraperitoneal segment, people were wondering coiled versus straight. Anybody have feelings on that? Arsh, do you want to take that one?
Yeah, I think it's a very contentious space. Multiple randomized control trials suggesting a benefit to doing a straight catheter. Yet, if you look at North America, by far the most popular catheter that's being placed is a coiled catheter. So, I think we need to do some more robust look into what the actual right strategy is.
That is a great segue because we are going to be producing a paper on that shortly. So we do hope to have future webinars that kind of hit the papers and hit the hot topics. I think we need one on timing in terms of buried versus non-buried, urgent versus non-urgent. So hopefully people enjoyed this for our first webinar. I mean, one of the things we've learned from the registry is we originally, when we proposed it, we thought we'd be getting to sort of best practices. But I think we've found that there's different ways to do this, and it's really more of discussion of the pros and cons of the different approaches as opposed to just one size fits all. And this discussion today I thought was fantastic, talking about all the different nuances and the pros and cons. So I hope everyone enjoyed it. I hope we got to most people's questions. And we will look through the questions at the end of this, and we're going to send out a document to all of the people registered for this webinar, see if just in case we didn't answer all the questions. So Dr. Morris, Dr. Penner, Dr. Jane, I just want to thank you all for your time. It was great. And Rob, really enjoyed it. And please look forward to doing the next webinar probably in a couple of months.
Now, just to point out, the recording of the webinar will be available on the ISPD YouTube channel for those of you that want to go back to it after the fact. And I just echo Matt's comments. Thanks to all three of you for participating today. The conversation was great. Really, really enjoyed the discussion.
Thank you for inviting us.
Take care, everybody.
Thank you. Thank you.
Bye.